Hello. Hi students. Good evening everyone. Good evening. Sorry for the delay. Actually there was some technical snag at my studio. So I had to just there was some electricity default. But anyways I would be taking the class from this place. So I welcome you all to Unacademy, and let me tell you about this exam, which is Ultra Combat 2.0, and this is very useful. Yeah, hi Venkat. So you'll be having 50 questions and you need to solve it in 60 minutes, and you can see beautiful prizes. Lot rewarding exams, and I wish I could have been at your place when I was a kid, and these exams I would have definitely given. So don't miss it. And today's session, this is all on the revision. So we are going to discuss a lot of important things, and let us quickly, without wasting any time, let us start with the classes. So when we talk about the today's you can say important things. Okay. So try to, I'll just give me a minute. Okay. Okay. So the first question of the day is comment on the lesion. Comment on the lesion. So this is a question on SEEP. So you need to comment on the lesion. Okay. So what lesion is this all about? Yes, many of you are right. This is, no, not A. C4, this is not C4 actually. If you see, there is an ulcer, and this is an active ongoing ulcer. So definitely students, it's a C6. So I'll just you can say, okay. So this was the question that you have in front of you, and let us understand the solution. So what is this SEEP classification all about? Let us try to understand it first. The SEEP, this is nothing. I'll take a broad, yeah. SEEP is nothing but it is the classification for grading of venous insufficiency. Grading of venous insufficiency. Now, do you know, if you have seen the pattern of last 5-7 years, every exam we have one question from the vascular surgery, and this is what is very important. So let us try to understand and quickly revise the concept of SEEP. So when we talk about SEEP, just a minute. I'll just take 1 minute of yours. Okay. So when we talk about SEEP, what are the important things that we need to understand in this SEEP? What does C in this SEEP stands for? C in this SEEP stands for clinical. Now when we talk about clinical, what are the things that we need to understand? C1 is a joint term for telangiectasias, and also for reticular veins. Now you need to understand that reticular veins are the veins which are dilated to a caliber of 1 to 3 mm. So more than 1 up to 3 mm veins, and telangiectasias are less than 1 mm veins. So more than equal to 1 up to 3 mm, these are telangiectasias and reticular veins. Now C2, when you talk about C2, they are what are known as varicose veins. Now when you talk about the varicose veins, they are the ugly looking veins of more than 3 mm caliber. So C1 and C2, they are very important things. When you have C2, you need to also assess whether the patient is symptomatic or asymptomatic. So if the patient is asymptomatic, you shall be writing it as C2A. If the patient is symptomatic, you will be writing it as S. So So there is nothing known as A, B, C. So it's either A or S. And then there is something which is known as R. What do you mean by R? This is known as recurrence. So if there is recurrence post successful management, that is known as C2R. Then what is C3, students? C3 stands for edema. So if there is edema, that is known as C3. What is C4? C4 includes what? All the skin changes. Now when you talk about skin changes, we have C4A. What is C4A? This is known as pigmentation. Pigmentation. What is C4B? What is C4B? Anyone from audience? What is C4B? Answer is, you must have heard of something which is known as LDS. What is LDS? Lipodermatosclerosis. Lipodermatosclerosis. Then C5 stands for healed venous ulcers. So healed ulcer. And C6 stands for, excellent Prithvi, C6 stands for non-healed ulcer, non-healing ulcers. So first of all, students, not only C is important, even A is important, E is important, P is important. So when we talk about E, what do you mean by E? E means etiology. And when we are talking about etiology, it could be by birth, that is E congenital. It could be not by birth but not associated to any cause, that is known as E primary. That is known as E primary. And then students, it could be secondary to some cause. So that is known as secondary. So like post trauma, post DVT. So that is E. Then you have A. What does A means? A means anatomy. So when you talk about anatomy, it could be AS, that is something belonging to superficial venous system. Superficial venous system. And then we have AP, that is belonging to the perforator venous system. And then we have something known as AD, that is deep venous system. So all these things are very, very, very important. So AS, AP, AD. And this actually makes a very important part. Then we have students P. P stands for pathophysiology. Pathophysiology. Now when you're talking about pathophysiology, it could be PR, that is associated with reflux. It could be PO, associated with obstruction, or it could be PO plus R, both obstruction and reflux are there. So this is what is making it CEAP. So now if you see this question, what is the SEEP of this lesion? This is a non-healing ulcer, and thus the answer will be what? C6. Now this is what is very, very, very important. Let us discuss one more question. So from vascular surgery only, I'll discuss this question. A newborn, tell me the answer for this. A newborn presents with recurrent emesis and failure to thrive. Following is the barium follow through. What are you looking at? Comment on the diagnosis, comment on the causes, comment on the types, and comment on the management. So this is a very easy question to answer. Very, very, very easy question to answer. Can I have it from the audience? So what are you seeing? You are seeing a patient, a newborn, with dilated stomach and the dilated duodenum. So from this question, how shall you crack it? Just try to Venkat, it could have been pyloric stenosis, but then why is the duodenum dilated? So this is stomach. So what are you seeing in front of you? You are seeing dilated stomach. Point number 1. You are seeing dilated stomach. Then the second thing that you are seeing is you are dilated duodenum also. But say first of all, in perforation, Naveen, we don't do excellent. It's a case of atresia. We don't do the barium because of the contrast induced peritonitis. So yes, this is a classical double bubble appearance. Double bubble appearance can be seen on X-ray also. It can be seen on barium also. And this is actually a case of duodenal atresia. So first thing that you have in front of you, that this is a case of duodenal atresia. Are you getting this point or no? Yeah, very good, DK. Next is what are the causes, what are the types, and what is the management. For that we'll go to the next sheet. So when we talk about the duodenal atrasias, what are the important must know things? So duodenal atrasia, this is very important. Actually, if you talk about the causes, there are multiple causes of duodenal atrasia, or you can say associations if I say. So we can have it associated with what? Biliary atrasia. So biliary atrasia can be a reason for duodenal atrasia. Second is, have you heard of, or you must have heard of, annular pancreas? So annular pancreas is second reason. So we have annular pancreas, we have biliary atrasia. Then you must have heard of Down syndrome. It could be a feature of Down syndrome. Excellent, Prithvi. Very good, bache. Very good. Then it could be associated with something which is known as polyhydramnios. Then one more thing is, students, it could be associated with something which is known as malrotation. So these are the classical associations of, yeah, preterm baby, you have this, but it is not always preterm. It's not a risk factor. So yes, biliary atresia, annular pancreas, Down syndrome. Now the next thing that we intend to discuss is what are the types. So when you talk about the types, they are again very important. But say there could be a type 1. What is type 1? This is presence of the duodenal webs. So presence of webs, this is what is known as type 1, duodenal webs. Now what do you mean by duodenal webs? This is an atrasia. Where you actually have a web present here. Now what happens when there is a web present? The gastric contents want to push itself through the duodenum, but due to presence of web, actually they cannot, or there might be a hole also in this. So what happens? This is the atrasia segment, and the web actually tends to get distally stretched off. Why? Because of the pressure, and that is what is just looking like a windsock. So if you go to airport or if you go to beach, you will see something which is known as windsock. I hope you must have heard of that windsock, and that is why duodenal atrasia is referred as windsock defect. And what type of duodenal atrasia is classically known as windsock? Answer is it is type 1. So type 1 duodenal atrasia is known as windsock. Then what is type 2, students? Type 2 is atrasia without separation. So atrasia without separation of mesentery, and this is what is very important. So whenever there is atrasia, there will be first the atrasia of the bowel, and then there will be atrasia of the mesentery. So mesentery in this case is still intact, and this is what is known as type 2 atrasia. Then what is the next one? It is a type 3. So it is atrasia with separation of mesentery, and this is what is very important. So if you talk about this type of atrasia, it is something like this. This is like this. It's very important. So atrasia with separation of mesentery. The next important thing that you need to understand, kids, is what is the workup. The first line investigation that we have is USG abdomen, but investigation of choice is a barium follow through. So it's a barium follow, and this is what is very important, barium follow. Now what is the management? Try to understand the management. The treatment of choice is duodenostomy. So duodenostomy, but this has a typical way of doing a duodenostomy. This is like diamond anastomosis. This is what is very important. Hi Vishov, hi. So what is the concept of diamond anastomosis? This is important. देखो क्या होता है. So this is one segment. Obviously the proximal segment will be distended, and the distal segment will be what? Collapse. So it's very important that you do the anastomosis in a proper way. because if you try to anastomose this segment with this segment, it is not possible because of the disparity of the what diameters. So what you will do, you will make a longitudinal incision here. Suppose you want to do the anastomosis, you will make a longitudinal incision here. You will do a longitudinal incision here, but when it comes to the anastomosis, you will place these bowels perpendicularly. So the orientation of incisions should be like this. Why and what is the advantage with this? You have the maximum aperture covered, and that is what is known as a diamond shape anastomosis. So duodenostomy, yeah, I'll share. Don't worry. Okay, so duodenostomy, this is what is very important. Next is, let us go to the flashcard section again. So this is a classical double bubble sign. Just a minute, what has happened? Students, just give me a minute. I think there is some problem with this. Just a minute. Okay. The next question that you have is this. Okay. Identify the lesion and also the grade. So patient, I'll give you a brief history. A long standing patient, or you can say chronically bedridden patient. So I will give you a history. A bedridden patient presenting to you with this kind of thing. So what is it? What are you seeing in front of you? What is the grade of the lesion? The very same question was asked in INI-CT, in NEET PG, even in FMGE entrance exams. So this is a question which has been asked a lot of times. Excellent. It's not a piloneedle sinus, students, because piloneedle sinus is not like this. Piloneedle sinus is totally different. Yes, it's a pressure sore. So you can say it's a decubitus ulcer. You can call it to be a decubitus ulcer. You can call it as bed sore. You can call it as pressure sore. So there are a lot of things that you need to understand. So pressure sores, bed sores, and decubitus ulcer. The next important thing that you need to understand is what is the grading, what is the concept, what is the management. So let us try to understand the concept of bed sores, or you can say the pressure sore. Bachche, do you know it is the pressure dependent ischemic necrosis. Pressure dependent ischemic necrosis on the dependent parts in patients who are on prolonged immobilization. So hota kya hai? Let us try to understand. It is pressure mediated necrosis. Pressure mediated necrosis. And what are the sites where these necrosis happens? Try to understand. This is very simple. So pressure mediated necrosis over the dependent parts of the body. Now this is what is very important for you to understand. What is the concept of this pressure sore? Now whenever you are sitting or whenever you are on the bedridden posture, there is something which is known as P external. So from outside the pressure is coming, and this is what is referred as pre-external. Do you know this is the capillary that you have? So this is the capillary that you have in front of you, and there is an outside pressure which is known as P external. Do you know this P external could have collapsed this capillary, but in a normal patient it doesn't happen. Why? Because of there is a subcutaneous fat. There is subcutaneous fat which acts like a shock absorber. So now patient who are chronically bedridden. So if you talk about a bedridden patient, the first thing that happens is there is atrophy of pad of fat. So atrophy of fat, and therefore all the pressure is directly applied on the capillary. Now in order to keep the capillary distended, there is a pressure which is required, and this is what is known as COP. So what is COP? COP is referred as capillary occlusion pressure. What is capillary occlusion pressure? You can say this is the pressure required to collapse the capillary, and this is actually referred as somewhere around 30 to 32 mmHg, and this is again a question. So 30 to 32 mmHg of the pressure is required to collapse it. Now wherever the P external is more than COP, there will be what, student? Collapse of the capillary, and therefore there will be ischemia, and ischemia will lead to what? Necrosis, and this necrosis will ultimately cause what? Ulcer. And this is what is a very simple concept. Now you people will tell me what is the order, what is the most common site where we have this pressure induced necrosis. So what is the order? Incidence, if you talk about, tell me the order, the most common site. I always use a mnemonic in my classes also, and I tell it to my students also, that there is a mnemonic which is known as it's he man. It's he man. So there's a mnemonic which is known as it's he man. This is my own mnemonic, I have made it. So I stands for ischium. So ischium is the most common site, and then we have trochanter. What is this trochanter, students? This is greater trochanter. This is greater trochanter. Excellent, DK. Then we have sacrum. So don't think that sacrum is the most frequently seen site. So sacrum. Then what else, students? What else? It is then heels. It is then heels, and then it is what? Malleolus. And after that it is occiput. So try to understand, this is the order. Next is, what is the grading? Now grading is also very important. When we talk about the grading, as this question is on the grading, grade 1 is merely the presence of what? Bruise. So there is bruise, this is grade 1. Yeah. What is grade 2, students? This is again important. This is partial thickness ulcer. Partial thickness ulcer. Then we have, what is grade 3? This is full thickness ulcer. So we have partial thickness, and then we have full thickness ulcer. And what is grade 4? It is grade 3 plus destruction of deeper structures, and this is what is very important. So destruction of the deeper structures. So if you see this question, students, can you see that it is a full thickness ulcer with the bone? The part of bone also is necrotic, the muscle also has been invaded. So one thing is clear, that this is what? A grade 4. I hope there is no doubt in this. So it's a grade 4 without any doubt. Next is, let us talk about the management part of this. So when you talk about the treatment, the first thing that you need to understand is debridement. Why? Because if there is a pressure sore, there will be chronic inflammation and then infection super added on this. And along with that, weight offloading. So the main cause is the weight which is causing compression. So even if you do a debridement and you don't do the weight offloading, there will be chaos which will be supervening on that. So how do you do this weight offloading? Can I have it from audience? You know, we can use air mattress. We can use, you can say, water mattress. All these things are very important. After that, what else will we be doing? So debridement, weight offloading, antibiotics, and along with that, once you debride, you need the wound also to heal. So plus minus skin grafting, along with that, plus minus vac. What is vac? And this is now what is very important. There have been a lot of questions asked on this. Yeah, you can use graft seeker, very good. Now I've already told you this vacuum assisted dressing. So vacuum assisted dressing, and this is what is very important. Excellent. Bache, suppose this is the wound. What you do, you put a special I'll change the color. Yeah, so there is a foam which is known as carbon, yeah, you know, charcoal fiber, so charcoal fiber, this is special foam, and inside this special foam you have a capillary, and this capillary is connected with a what? Machine, and this machine has a chamber, and this is actually having minus 125 mmHg pressure. So do you know what happens? All the purulent necrotic material which is present here, yeah, it is siphoned off it is siphoned off and collected in this, and that is what is actually causing the pus to be evacuated out from the wound side, and thus if pus is not there, the local oxygen availability around that wound margins is enhanced, and that is actually going to promote the healing. And this is what is known as vacuum assisted dressing or negative pressure dressing. Are you getting this? Negative pressure dressing. These things are very important. One more thing that kids you need to understand is how to go for the prevention. So how to go for the prevention, I hope everyone must be knowing. Come on, I can have it from audience. Prevention is regular change of posture. Now this is what is very important. Regular change of posture. Now when we talk about regular change of posture, what are the time windows that we need to understand? Every 2 to 3 hourly. Every 2 to 3 hourly. For what patients? For bedridden patients. Excellent DK, excellent. For bedridden patients, it is every 2 to 3 hourly, and every 10 to 12 minutes. Every 10 to 12 minutes for 10 to 12 seconds. For what ridden patients, students? For chair ridden patients. And this is what is very important. So chair ridden patients, bedridden patients, both have a different thing. Do you know when you are sitting, actually the COP, normally what is the COP? The COP is only 30 mm Hg, 30 or 32 mm Hg. The P external, when you are sitting, in sitting posture, it may be 300, 400, even 500. So it's very high. That is why for chronically chair ridden patients, you need to change the posture every 10 to 12 seconds so that the local, you can say, circulation is improved. So let us do one more question. And okay. Chalo. Answer with this question. A young female presenting with recurrent abdominal pain with intermittent jaundice and ERCP shows the following thing. Tell me, what is it? Tell me what is it? How can you say it's a stricture? Okay. Once you have attempted, then I can discuss a lot of things. Excellent DK, excellent Venkat. देखो बच्चे, देखो. Try to understand. Now what is this? This is ERCP. This is a side viewing ERCP. How this is a classical side viewing endoscope. You can understand that the view option, the view side is this. So this is a side viewing endoscope. So definitely one thing is clear, that it has to be in the duodenum. So if I create an imaginary duodenum out of this is like this. But say the second thing that you need to understand, that what is this structure? This is main pancreatic duct. I hope that is clear. This is gallbladder. This is the cystic duct, and definitely this is what, students? CBD. So this is CBD going down, and can you see this CBD is doing nothing but it is fusing with the what? Main pancreatic duct. Yeah. And can you see this fusion is outside? So this is abnormal fusion of common bile duct with main pancreatic duct. And this is what is, why it is abnormal? Because the fusion is outside the duodenum, and that is what is known as abnormal biliopancreatic junction. So this phenomena that you see is what is known as ABPJ. What is known as ABPJ? So what is this case scenario associated with? First of all, try to understand, this will be a classical case scenario of choledochal cyst basically. And choledochal cyst, This is because. So let us try to understand. This is abnormal biliopancreatic junction and why there will be things. Let us see. Let us see. It will take 2 minutes for me to explain a lot of things. So let us understand this concept of abnormal biliopancreatic junction and the concept of choledochal cyst. So choledochal cyst. When we talk about the choledochal cyst, what is the concept of choledochal cyst? It's very, 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 very important. Majority of them, now try to understand, this is duodenum. This is the common bile duct which is coming down. And this is the common main pancreatic duct. And together they are going to form the what? Ampulla of Vater. Are you getting? So this is a normal fusion. And what is normal fusion, students? Intraduodenal fusion of CBD with MPD, with main pancreatic duct. This is what is very, very, very important. Intraduodenal fusion of CVD with main pancreatic duct. Ab samajhte jao what are the things which are going to happen now. What is abnormal biliopancreatic junction? Try to understand. What is abnormal biliopancreatic junction? The case number 2 which you are seeing in your image that I have shown you. So this is suppose common bile duct and this is what is main pancreatic duct. So if you see, this is the fusion of main pancreatic duct with the main bile duct outside the duodenum. Here it was inside, here it is outside. Now what it will be leading to? Answer is because of this there shall be reflux of the pancreatic juice. So because of the abnormal biliopancreatic junction, there will be reflux. There will be reflux of pancreatic juice into what, students? Into the bile duct. Now do you know that pancreatic juice is very dangerous? Very, 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 very dangerous in fact. And this is going to cause damage to, it is going to cause damage to CBD, and because of this damage to CBD, there is erosion plus thinning of the CBD, and because there is erosion plus thinning of the CBD, there will be what? Dilatation of the CBD, and if there is dilatation of the CBD, this is going to lead to what? Choledochal cyst. And this is a focal dilatation, the site at which actually the damage happens. So this is going to lead to choledochal cyst. Now try to understand lot more things. Now when there is erosion and the thinning of the bile duct, erosion and thinning of the bile duct, what will happen? What will happen? There will be incipation. There is a word which is known as incipation of biliary proteins. Now when there is incipation of biliary proteins, what is going to happen, students? The protein, what is incipation of biliary proteins? I would refer them as protein clots. These are protein clots. So these are the protein clots which have formed, and now just see what is going to happen. This is what is the abnormal junction, and these protein clots will actually cause temporary blockage, and when there is a temporary blockage, what will happen? So temporary blockage of CBD, this is going to lead to what, students? This is going to lead to something which is known as obstructive jaundice, and this is going to, if there is blockage of MPD, this is going to lead to what? Acute pancreatitis. Now try to understand, whenever there is temporary blockage of the bile duct or temporary blockage of the main pancreatic duct, there will be increased pressure, and this increased pressure will wash away the protein clot. So increased pressure will cause the what? Washout of the protein clot, and if there is washout of clot, what will happen? What clot? Actually the protein clot. There is relief of jaundice, and also the pancreatitis, and this is what is the reason for intermittent pancreatitis that you see in a case of choledochal cyst. So in choledochal cyst, we get to see, just a minute, just a minute. So this is the reason why you have the intermittent pancreatitis. So what is the, this is the reason. So what do you see in choledochal cyst? What is the classical presentation? This is seen in young, actually there's some problem. Yeah, wait, just a minute. I'll have to wind up anyways. So females with right upper quadrant mass, with right upper quadrant pain. So right upper quadrant mass, right upper quadrant pain with intermittent jaundice and pancreatitis. This is what is a classical profile of what, students? The choledochal cyst. So tomorrow we'll discuss with the similar things, and I will be continuing with the series. So I have some urgent, I have to stop the class, there is some problem. So I'll continue it later on. So I hope you enjoyed the session. Okay, till then.